All right, guys, I think we're going to get started. Um, Hopefully everyone can hear on Zoom too. So I'm Dr. BK James, and really excited to welcome you guys to the program today. This is our second annual research exposition, and we appreciate those of you in attendance and those of you on Zoom, and hopefully more will be joining. So with the recent Supreme Court decision to dismantle affirmative action, programs such as this become even more important. The impetus of this program initially was a diversity grant. However, we didn't get that. And eventually we were able, through the support of Kelly's actually at the back there, McBride and Dr. Howell, to get funding through the Walks Weingarten Charitable Trust to be able to run this program. We are now in year 2 of our funding, and we were able to take our learnings from last year and make, I think, a better program this year. Partnership with Dr. Cherise Hamblin, who is here by my side, and her colleagues from Patients Are Waiting, has helped to make this program an overwhelming success. She's been there from identifying patients to interviewing with me, to reading through all of the applications, and she's just been a wonderful collaborator. So I'm going to have her say a few words about Patients Are Waiting and about her involvement in the program.
Well, thank you so much. I mean, I'm just down the road in Lancaster, and honestly, this summer has flown by, which we've all mentioned, and it's crazy to me to be meeting you in person for the first time for all of you. So, but the main thing that I want to leave you all with that are presenting is that patients are actually waiting for you, and so we want to see you get through this. And our mission to eliminate health disparities by increasing diversity in medicine doesn't end, or our contact with you doesn't end with this program. That we'll continue to walk alongside you on your journey, and so you all have my number, and then we engage the full force of PRW to be your advocate, your support, and just walk along this journey with you. And we hope that it lands you as an ObGyn, but one of you may be the president of American College of Obstetrician Gynecologists, who knows. And so I'm really excited to look forward at how the seeds that were planted this summer continue to grow, and the great things that you all are going to do.
All right. And expect questions from her. She has a question for everyone. All right, so this year we had 47 applicants, so up from 20 last year. So just in terms of the importance and how this program has launched. Cherise and I read each application, interviewed 10 students, and selected the 5 of you who are here today. Over the course of the afternoon, you're going to hear from each of them. They've shown dedication and commitment this whole time, from a lot of technical issues this year, administrative tasks, and just making sure that they were all involved with the program. They've spent 8 weeks with us that have flown by and have endeared themselves to faculty, their mentors, people they've rotated with. I've heard nothing but rave reviews from folks you've shadowed, the residents, medical students, and staff. Today, the focus is going to be on your research. Each of them will present for up to 15 minutes or so, and then with 5 minutes or so for questions. And I'll keep an eye on the clock so that we keep things timely. So first up is going to be Ngozi Ikpenyama. She's been mentored by Dr. Uduak Andy and Pam Levin from the Division of Urogynecology. Ngozi is a recent graduate of the University of Delaware, where she completed her Bachelor's of Science in Nutrition and Medical Sciences. Throughout her college career, Ngozi has taken part in a variety of experiences to shape her perspective and approach to medicine. In addition to research with a focus on health disparities, she was a volunteer emergency medical technician and nursing assistant at a children's hospital. Within her institution, Ngozi served through several roles, such as peer mentorship for minority students, president of the African Students Association, and a longtime member of the Cultural Program and Advisory Board. She remains steadfast in her commitment to a career in medicine with special interests in women's health, nutrition, and health equity. Ngozi is very grateful to have had the opportunity to partake in such an enriching experience and will carry lessons learned from her summer at Penn into her future career. Come on up while we pull up your slides.
Hi, everyone. Good afternoon. How are we doing? Good. Okay, well, my research this summer was on assessing outcomes of community engagement efforts on diversity in the Move On Up study. So the Move On Up study is a study for women who are 70 years of older and experience bladder leaks, also known as incontinence. There's different types of incontinence, but this study focuses on urge incontinence, which is when you have a sudden urge to urinate and often leads to bladder leaks before you can make it to the bathroom. 1 in every 3 women will experience this in their lives, and the condition can significantly impact quality of life. So there is a tie between falls and urinary urge incontinence. Older women are at a greater risk of falling than men, and women who are 70 years of older have a 40% chance of suffering from urinary incontinence. So the tie between this is that the risk of falls doubles for women who have urge incontinence, and this can sometimes be as they're rushing to the bathroom, trying to make it in time, or if they're getting up in the middle of the night and they have that urge to go. If it's dark or if the environment's unfamiliar, it can result in them falling. So here are some existing interventions for urinary urge incontinence. So one of them is pelvic floor muscle exercises. The thing about these is that they often ignore or exacerbate fall risk in women who are older. So in that way, they can be counterproductive. Another intervention is overactive bladder medication. The thing about these is that they're tied to cognitive decline, which can also increase the risk of falling in an older woman. Lastly, there's physical activity or exercise. This can also be harder for women who do have urge incontinence, as they might feel shame or embarrassment if they have bladder leaks while they're exercising, and it might also affect the types of exercises they can do. So basically the purpose of this study is to kind of address that issue, finding a training program that works to help bladder symptoms while also keeping in mind the fall risk of older women. So our hypothesis is that falls in older women with urinary incontinence are the result of urinary urgency-related anxiety in the setting of reduced muscle limb strength, poor balance, and environmental hazards. So this is the Move On Up study. Move On Up stands for the mobility and voiding exercises in older women with urinary incontinence. So this is a randomized controlled trial. It's NIH funded for women who are over 70 and experience urinary incontinence. And as I mentioned earlier, it's a bladder and exercise training program to help address bladder control and reduce the risk of falls. So here is the study design. Women who are 70 years or older and have urge incontinence are recruited. They're verified for eligibility, consented, and they have baseline assessments. At that point, they're randomized into either the exercise up group or the control group. Within the exercise up group, they have physical exercise, bladder training, and home hazard visits from an occupational therapist. Within the control group, they're just given educational booklets on fall prevention and urinary incontinence. And both groups are assessed every 3 months for a duration of 12 months. So here is the recruitment plan for the study. We plan to do flyers in community clinics, My Penn Medicine, social media advertisement, and community engagement. So these are just some examples of the flyers that the study uses. What's really interesting to note here is how the flyers have different representation, which is very important when you are recruiting from community members. People often are more willing to listen to something they feel they can relate to and they feel they are represented by. So this is really something interesting that the study makes sure to do. So just more on community engagement and research. This is a mutually beneficial relationship between the community and the research staff. It's important because a lot of the times it is a major source of diversity for the sample for the study. It gives us a more accurate picture of what it looks like from the community that we're doing the study inside of. And it's also really helpful in terms of giving us an actual opportunity to create policies and initiatives that will benefit those communities as well. So here are some community engagement efforts within the Move On Up study. They have made sure to connect with senior centers, religious communities, community-based clinics, and networking fairs. So additionally, Move On Up is connected to the Penn Bladder Health Network. This is an inter-partnership between different departments here at Penn, such as geriatrics, urology, ObGyn, family medicine, and other organizations in Philadelphia, such as senior care organizations and elder advocate organizations as well. The whole purpose of this organization is to spread education about bladder health and just promote bladder health among women in the greater Philadelphia area. Some of the things they've done have been bladder health talks, as well as referring patients to studies that they might be interested in. So these are excerpts from some of the bladder health talks that they do. Just teaches people more about bladder fitness and bladder health, gives them a crash course on the anatomy, kind of tells them what a healthy bladder should look and feel like, as well as gives them a way to learn about this information that they might not have had access to. So these are the booklets that are handed out at community engagement events. Again, it gives them a rundown on the anatomy, teaches them more about incontinence, and it also gives them a way to contact the study if they're interested in learning more. So my role within the study, I wore a couple different hats this summer. So I did a couple different things. I pre-screened potential subjects for enrollment and eligibility. I was databasing study materials, organizing visit materials as well, and attending community engagement events. At those events, I would distribute study materials to potential subjects who were interested. I collated and summarized community engagement efforts to date, analyzed recruitment demographics, as well as shadowed in the clinical and surgical settings in the Department of Urogynecology. So for the results, these are the recruitment outcomes to date so far. They have screened over 230, pre-screened, over 230 women. Over 100 have been enrolled into the study. They've had partnerships with over 25 organizations, and they have given bladder health presentations to over 700 women and men. So this figure shows the number of pre-screens by recruitment method. You'll note here that a significant amount of people that were pre-screened and recruited into the study were found through community outreach, so it's definitely important, and you can see that it is working in terms of getting the study out there. Additionally, you'll see a lot of people were found through My Penn Medicine. There's also a good amount here that were found through the other category, and these are basically people who were referred through people that are already in the study or people who found about the study through the Move On Up website. So this figure shows the racial demographics of the pre-screened women. As you can see, it is majority white. There is a decent percentage of Black women represented in the sample as well, and a very small percentage of Asian American. And you'll notice that the other races don't appear on here simply just because there wasn't enough data for them to appear on this figure. So this table shows the just a summary as well of the community engagement that they've done. So you'll notice here that senior centers and fairs are very successful in finding older adults in general, but also finding people that are potentially interested in being a part of the study. This figure shows the methods of recruitment outcomes by race. I think what's really interesting to note with this figure is that with the My Penn Medicine women that were recruited, a significant amount of them were white. And if you notice, when we go to community outreach, that's where we start to see more diversity in our sample, and as well as the other methods, as I mentioned before, referrals and the website. This figure shows the community engagement outcomes by method. So it was interesting to see that religious communities and senior centers were the most popular in terms of finding older adults that were interested in being screened for the study. This figure shows racial demographics of community engagement outcomes. So like I said, in the last figure, senior centers and religious communities were very popular for finding older adults. And this kind of just shows the racial breakdown. It's kind of interesting to note here how in terms of community engagement, the only place that we did see Asian representation was at the senior centers. And also with the community-based clinics, there was no racial preference between Black and white. So here are some of the findings just to summarize the results. We found that senior centers had the highest recruitment percentages for Black and Asian women. Religious communities had the second highest recruitment percentages for Black women, but very low percentages for all the other races. Community-based clinics didn't show racial preference in terms of recruitment percentages between Black and white women. Most pre-screened white women were found through My Penn Medicine. Over 50% of the Black women were pre-screened, were found through community engagement, which makes a huge contribution to the diversity of the sample. And 75% of the Asian women that were pre-screened were found through a senior center. So just some points of discussion. Something we noticed is that there was a lack of Asian, Hispanic, or Latinx representation within the study participants. And this can be for a couple different reasons. Something that did come up when looking through a lot of this data was the issue of language barriers when contacting certain communities. A lot of the times that would be an issue when trying to network with them and trying to plan these events to come and present to them. So that can definitely be a major reason why we see a lower amount of Asians and Hispanic Latinx participants being pre-screened and enrolled as well. Additionally, there's importance of tailoring marketing materials. So kind of those flyers that I had shown earlier, as I mentioned earlier, people do relate to things that they feel they're represented by and are more willing to listen when they feel that the study is, there to help them and about them. Lastly, there's a possibility of people of color having less trust with their providers, and that can explain why we see so many women that were pre-screened that were white through Penn Medicine compared to us not really seeing as much diversity until we go through community engagement and other methods. Sorry. So for some future directions, there's a possibility of considering translators to reach those communities where a language barrier does exist. Considering making diversity within the sample a priority during the recruitment stage in order to get more even distribution, as well as considering a broader variety of locations for community engagement. So some of the lessons learned throughout this program there's the importance of community engagement and recruitment and diversity. A lot of the times we see certain groups of people that are left out of research or just don't have access to this education in general, but it is important to take the steps to go out into those communities and make sure that we are including those people that we often see missing. Community engagement is very involved and requires a lot of work, which I did not know before I did this, but it's a lot to maintain those partnerships with a whole bunch of different organizations, and to find them in general is even just a whole job within itself. So that was definitely something that was very interesting to see. It is a difficult task, but it's really important, as I said, to ensure diversity and that we are reaching everyone. Yes, that's the end. Thank you to the coordinators and my mentors, Dr. Andy and Dr. Levin, Dr. Hamlin, Dr. James. Yeah, I think it kind of does depend on the situation. I guess delivery is different depending on who you're speaking to. But I think overall, when talking to people, I just tried to find something I could relate to them on and kind of just tried to approach them as a person, not as a research subject. And then from there, kind of just bring out the pamphlets like, hey, by the way, bladder health is important. So, yeah.
One more, we'll have that be the last. Sheila, yeah, question?
Sheila, do you have a question?
Who's got it, but she's muted. Oh, she can.
Oh, here you go.
Hi, I think you can unmute. Did you have a question?
I think she unmuted. Oh,
Okay. Where's the
The
chat?
chat's down there.
Okay.
Oh, okay.
All right. Awesome. Community engagement considerations for diversity, community action agencies, public health clinics, faith and religious organizations, charitable organizations, support services, programs, housing assistance, and multicultural immigration services. Lots of recommendations for you guys. Off-site areas, libraries, post offices, community centers, laundromats, grocery stores, food marts, thrift, hospice, stores, public transportation, train, subway, metro, bus. Also consider ethnic minority native newspapers. Thank you.
Oh, that's awesome.
Awesome.
All right.
All
Well,
right.
thank you, everyone.
All right, so I'm going to introduce our next student, Isabella Bennett. She's been mentored by Dr. Sarita Sonalkar and Chioma Ndubisi from the Division of Complex Family Planning. Bella Bennett is a third-year student at Spelman College in Atlanta, Georgia, where she will complete her bachelor's in chemistry. She's a Philadelphia native, interested in women's health, reproductive justice, and international studies. As an aspiring ObGyn, Bella understands the importance of using her talents and refined skill set to help those around her. She's highly engaged in her surrounding communities, with her most favored roles being a student ambassador at Spelman College and a tutor for inner-city Atlanta youth. Academically, she continues to excel as an honors student and has earned a place on the Dean's List every semester. Bella acknowledges the prestige of this program and feels extremely grateful that she was granted the opportunity to learn from such an innovative community. Bella, we're excited to hear what you have to say.
So here I just have a brief presentation interview. I'll start by introducing the project and my role within the study and how I conducted my literature review and use those findings to choose a framework and create a code book, and then just other things that I learned throughout the program. Okay. So the topic of my research was the qualitative analysis of postpartum contraceptive counseling. So just some background for this study. The study took place in Accra, Ghana, where the contraceptive prevalence rate is only 23%. There is a high usage of smartphones, and the study took place in the family planning units in 3 public hospitals in Accra, Ghana. So here I have pictures of 2 of them, but it's the Mamobi General Hospital, the Naswam Hospital, as well as the Ga West Hospital. Okay. So prior to the study, researchers had conducted a search for other studies that had been done that related to the interventions that would improve postpartum family counseling and uptake. And the search had revealed that a key component to decreasing the rate of short interval pregnancies was ensuring that appropriate counseling and access to a variety of methods was available. So the purpose of this study was to evaluate the implementation and effectiveness of the World Health Organization app that would be used during routine clinical practice after delivery. So the study was conducted using a stepwise trial in the Greater Accra and Eastern regions of Ghana. So here was the introduction of the postpartum family planning package, or the PPFP, implementation strategy at the 3 hospitals that I had mentioned. So the strategy of this was to combine the use of the app as well as educating providers properly on, the proper procedures, as well as really increasing the usage of one-on-one counseling. So to make sure that everything was running smoothly, there was an observation of the inpatient postpartum encounters, and that took place over the course of a week, and that week was selected randomly. So the primary implementation outcome was fidelity, and fidelity is defined as the proportion of encounters where all appropriate family planning methods were discussed. And then the primary effectiveness outcome is defined as the proportion of clients who had received a method of birth control prior to leaving the hospital. So here, I just have some snapshots of the app. So you see there are different methods of contraceptives here, and you see the number next to it, which correlates to the scale, which tells you how the birth control should be used and when. So the implementation of the PPFP package was effective in promoting the client's decision to select a contraceptive postpartum. So we had just over 2,000 participants enrolled in the study, which lasted about a year. And it was shown that when counseled individually, clients were actually 4 times more likely to have discussed all the appropriate methods of contraceptives. And clients were also about 3 times more likely to make a family planning method choice prior to discharge post-intervention compared to the rate of 18.3% before we had intervened. So the secondary analysis was a part of the study that I was a part of, and the research question was, does a structured contraceptive intervention improve contraceptive counseling quality? So in this study, we also explored the clinician's perspectives of one-on-one counseling. So my role in this was conducting lit reviews, through my lit reviews, identifying key components of quality contraceptive care. From here, I selected an appropriate code framework for a code book that I would create later on, and then just how I had created the code book using the P3 framework. Okay. So here we have the P3 framework, and it was created by Robert Bernardzic. The P3 model considers all three levels of clinical encounters. So we have the practice, the provider, and the patient, and all the factors that would impact each three of these levels. So it builds off of key components of many theoretical models, including the health belief model and the theory of planned behavior. The framework yields a model for preventative care, and it can be used in different settings. So here we have just different codes that align with each of the levels. As you see, the provider and patient have similar codes. And this is what I would use to create the code book. So prior to delving deeper into the study, I had conducted a lit review not only to familiarize myself with the material, but to investigate what data had been gathered thus far. And I looked at articles that have focused solely on postpartum contraceptive care in sub-Saharan Africa, since that is where Ghana is located. And given the region and the relative novelty of the subject, the amount of articles were limited, but I was able to gather information. So my initial thought was that quality of contraceptive care would be measured through the number of women who chose a method of contraception and contraceptives, And through my lit review, I had realized that that was not the case. And I had extracted these factors as some of the things that would have influenced the quality of care. So one of them was income setting. So in areas where socioeconomic levels were lower, there were less hospitals, they were more likely to be understaffed. If there was a low contraceptive prevalence, then people were less likely to ask for contraceptives or even think to get more information about it. Age and marital status, younger women who were unwed had reported feeling that they weren't receiving the same level of care as older married women, and then improper training. So as I mentioned before, in lower income settings, they're understaffed, so a lot of people just had to be rushed through the training process, and even in places where they did have training, it was far away from where they lived. They weren't really getting paid that much, and the stipend that they did get, they had to use for housing and for food. So next, I had searched for quality of contraceptive counseling scales, or QCC scales. And this is just a way of measuring a woman's report of the interaction that she had with her provider. So whether she felt comfortable, whether she felt heard. And so there are actually many scales that are available, and they're very similar in the purpose, but they differ in how many questions they ask and the depth of them. So I chose to talk about this scale because I found that this was the one that went most in depth. So it is an interpersonal quality of family planning scale, and it's an 11-item and 1-factor measure scale. So some of the questions that would be asked would be, did you feel like your provider showed compassion? Did they respect you as a person? Did they answer all of your questions? And so you could rate your experience 1 through 5, 1 being poor and then 5 being like you had a really good experience. And so they would tally all of those scores into a total, like a grand total score, ranging from 11 to 55. So through my lit review and the QCC scales, I had pulled these key elements out of those two. So the ones that really stuck out to me were the validating patient concerns, discussions instead of directions, because a lot of women reported feeling like they were just kind of rushed through the process of choosing a contraceptive method. They weren't really given the chance to ask questions. Also neutrality, not allowing your personal opinions about the person or whether they're married or not to affect how you interact with them. So here I have an image of the codebook that I created. So the codebook was just a way of organizing my thoughts that either came from the P3 framework, so all the codes with the P3 came from the framework, or just any other codes that I thought should be in here. So I organized it by having the code, which is the domain, And then here we have a definition of when to use it, and for some of them I have an example of when you would use it. So this codebook would be used to attach the transcripts that we have from interviews with providers in Ghana. And anytime they mentioned maybe like a situational factor, we would attach that code to that quote from the transcript. So next steps, as I mentioned, I talked about the coding of transcripts. So here I have an example. So the code for this file here is the appropriateness of one-on-one counseling. So anytime one-on-one counseling was mentioned, you see we have the quotes here, and it was placed under this file. And so that will be done with the next set of transcripts. Then also the analysis for salient themes related to the intervention that may have affected contraceptive care quality. So outside of my research, I had the chance to shadow clinically. And so I was stationed in the Peace Clinic, which also spent time in the OR. And in some of my time there, I had saw contraceptive counseling, IUD and next one on insertions and removals, family planning consults, and pap smears. And it was really interesting to see the contraceptive counseling because since my research was based on that, it was nice to see it like done in person and how it's very patient-centered in the Peace Clinic, and there's a lot of neutrality. No one's being pushed in one direction. It's really up to the patient, and the provider just supports them throughout the way. And then when I wasn't in the Peace Clinic, I was on the labor and delivery floor, so I saw C-sections, vaginal births, VBACs, which is a vaginal birth after C-section, and also postpartum floor rounds. So just to close off, through this program, I learned that contraceptive counseling is more than numbers. It is about the patient's well-being, and it should always be patient-centered. I saw up close the beauty of ObGyn care and how this is probably one of the most vulnerable positions you'll ever see a woman, and how important it is to really be compassionate and patient with them as you support them through their process. Also learning how to deliver news that may not be, what the patient wants to hear, and also supporting them through that process. And also seeing how this is a very team-based field, and it's okay to look to those around you for support because they're there to guide you along the way. It's a very tight-knit community, and everyone wants to see you succeed. So I want to thank everyone who helped me along the way. I want to thank Dr. James and Dr. Hamlin for creating the program, which has allowed me to gain a deeper understanding of a field that I'm very passionate about and means a lot to me. Thank you to Dr. Sanalkar and the Peace Clinic for hosting me and encouraging me to ask questions along the way so that I could have a fuller experience. And also to Dr. Salva and Dr. Wong for my wonderful shadowing experiences that I had on the L&D floor and on the fetal anatomy ultrasounds. So thank you. So I didn't necessarily have research experience in the ObGyn, specifics of care there, but I did have an interest in women's health in general in sub-Saharan Africa, and I had done a presentation on it my senior year in high school. And from there, I had always wanted to join a research team like this where I could get a deeper understanding. So from this, I gained a lot because I did not have this deep knowledge. I mean, this is a very focused study on Accra, Ghana, but I just had an idea that women didn't really have access to the resources that they should, or it was harder for them. That's kind of all that I knew. But through here, I learned that I didn't even think about the quality of contraceptive care. So that alone was new to me, and just learning how that's executed and how it's studied. So I got that from this. Okay, thank you.
Next up, we have Bernice Okafor. She's mentored by Dr. Marissa Weiss, you're there, from the Division of Reproductive Endocrinology and Infertility. Bernice is a Bachelor of Science graduate of the University of North Carolina, Greensboro, and a Master's of Science graduate of Drexel University. Bernice's goal in becoming an ObGYN stems from combining her interest in researching ways to provide a faster diagnosis, management, and treatment of PCOS, and providing quality care to low-income and minority women. Her current interest is to explore reproductive endocrinology and infertility as a specialty. This summer, she enjoyed being mentored by Dr. Marissa Weiss and shadowing many ObGYN subspecialties. She's truly grateful for her experience and hopes to apply all she has learned from the summer program to her future career. And I'll say, Bernice, from the start, from interviewing her, talked about her interest in REI and PCOS, et cetera. So we searched out to the REI division to find a mentor, and we're so fortunate. Thank you, Marissa, for agreeing to join us this year.
Good evening, everyone, and thank you for coming. So before I started, I wanted to paint a picture for you guys. About 1 in 6 couples are diagnosed with infertility. When treating infertility, high-quality care is typically defined by the effectiveness of treatment, specifically achieving a live birth. Though important, effectiveness is only one aspect of high-quality care, particularly in infertility, which confer a significant physical and emotional burden on those affected. Research from other fields of medicine has demonstrated the value of prioritizing patient-centeredness in healthcare. However, this domain has been largely unexplored in the fertility literature. I will define patient-centered care and review the existing literature both in the U.S. and abroad on patient-centered fertility care specifically. I will also describe my role in this work and the lessons I've learned. Lastly, I'll propose a direction for future research. So where does the idea of patient-centered care come from? What is patient-centered care? In 2001, the National Academy of Medicine recommended 6 domains necessary for quality health care. A good practice involves safety, equity, efficiency, timeliness, patient-centered care, and effectiveness. As I mentioned earlier, there is an abundant literature on the efficiency and safety of fertility care. However, other domains like patient-centered care have received less attention. Let's define patient-centered care. The Picker Institute encourages a holistic approach to medicine and explains that patient-centered care involves putting people at the heart of health and social services. 8 domains were created for health providers to reference when looking to ensure patient-centered care in their practice. Patients should be seen as human beings first and should play an active role in their health care. Ensuring patients are centered in fertility care is particularly important given the increased rates of anxiety, depression, and social stress associated with infertility. Patient-centered care encourages patients to develop the knowledge and confidence they need to effectively manage and make informed decisions about their own health. When healthcare professionals work collaboratively with patients' needs and concerns are taken into consideration and help to in turn reduce their anxiety and depression and ease their fears surrounding intensive treatments. In the end, this leads to a positive patient experience with less misunderstanding between patients and their providers and fewer complaints. To better understand the components of patient-centered fertility care, I aim to review and understand existing international and U.S. literature. Synthesizing this work, I was able to identify aspects of care that may contribute to patient-centeredness and identify current gaps in literature. In the future, designing and implementing interventions to address these gaps will ensure patient-centered care is prioritized and measured in infertility. Most research pertaining to patient-centered fertility care comes from the Netherlands. Through both qualitative and quantitative work, Van Empel and colleagues developed an instrument to measure the patient-centeredness of fertility care, the Patient-Centered Questionnaire, or PCQI. Focus groups were used to discuss positive and negative patient experiences with couples who had gone through assisted reproductive technology, such as IVF. These discussions were transcribed and analyzed, and relevant quotes were grouped into 81 care aspects that make up the concept patient-centered fertility care. The PCQI is tailored to couples and included 127 questions that asked about patient experiences regarding patient-centered care aspects, the importance of each care aspects, background questions, a satisfaction rating, and a comment section. Results from the pilot study showed that continuity of care, respect for patients' values, and information could be improved at the clinic studies. Information about how and where to get psychosocial support was also difficult for patients to obtain, and authors believe this is because psychosocial care is not always a part of fertility care in the Netherlands. Using data gathered through validation of the PCQI, Dancet proposed a framework that looks at treatment through the patient's perspective. The 4 treatment dimensions considered included burden, effectiveness, safety, and financial costs. The framework also proposes that patients should be advised by professionals on effectiveness, safety, and costs, and that the results of systematic assessment of patients' experiences should define advice on burden. In Sweden, a different instrument was created by Holter and colleagues, termed the Quality from Patient's Perspective of In Vitro Fertilization, or QPP-IVF. This instrument was based on a previously designed QPP instrument that measured female and male perspective on their quality of general care. The QPP-IVF was developed by keeping questions specific to IVF patients from the original QPP and creating additional questions in order to measure specific outcomes and components of IVF. The QPP-IVF consists of components that include aspects of care, support, privacy, availability, and information and instructions before, during, and after IVF. In their pilot study, Holter asked participants to complete the QPP-IVF within 2 weeks. This is before their pregnancy tests, so that biased responses based on pregnancy results could be avoided. The results indicated that medical care and information were important components of patient-centered fertility care amongst the participants evaluated. In the PCQI and QPP-IVF pilot studies, the study populations consisted of mostly white Europeans and do not focus on socioeconomic statuses. So it's important also to note that in Sweden and the Netherlands, medical treatments, including IVF, are publicly funded. And the United States, in comparison, is vastly different, as the US population is more diverse and insurance coverage for fertility care is limited. The following studies will give insight to the limited research available in the United States. A qualitative study was done by Klissman and colleagues to find the important components of patient-centered care in the US. Telephone interviews were conducted with 37 individuals, including physicians, other healthcare providers, and patients. Patients and providers had differing treatment-related experiences, such as expectations, time frame for pregnancy results, and IVF outcomes. The authors concluded that patients wanted to be treated as people with respect for their values, preferences, needs, and education. Specifically, for care to be patient-centered, patients expect their providers to be more transparent about the challenges of IVF, be more understanding of emotional complexities they face, and manage their expectations and treatments with sympathy. Failure to do so revealed difficulties in patient-provider communications and relationships. The Shanley study was able to use a national database, the Fertility IQ questionnaire, to study patient-centered care. The utility of this questionnaire is limited as it was not developed for research purposes. It does, though, have the benefit of a large number of respondents. A patient-physician relationship that includes trust, good communication, and empathy were shown to be a central component to patients feeling that they had received patient-centered care in a positive experience. Surprising factors that have not otherwise been mentioned in other studies conclude that ancillary resources such as psychosocial support, provision of acupuncture during IVF treatment, and patient satisfaction with the billing department are associated with a positive patient experience. To align with the lived experiences of the United States, couples seeking fertility treatment, Duthie and colleagues proposed a revised version of the Dancet framework for patient-centered fertility care. The new framework retains much of the original framework with few modifications and 2 additional dimensions, time and genetic parentage. For patient-centered fertility care, discussion about a couple's goals, expectations, limits, and limits must be understood as an ongoing process and not as a one-time event. And providers should help patients identify and weigh the pros and cons across all treatment options. These include effectiveness, physical and emotional burden, time, cost, potential risk, and genetic parentage. Though validated tools that define and measure the patient-centeredness of fertility care exist in Europe, the patient population and care delivery model in the United States is very different. And as we discussed, existing studies are limited by sample size and data sources. This summer, I've learned how to do a comprehensive literature search, how to do an in-depth review of relevant articles, and how to write a narrative review summarizing my findings and proposing directions for future research. The next steps in the United States effort in researching the importance of patient-centered care would be to broaden the list of factors that contribute to how patients perceive the care they receive. Subsequent studies should also include how funding fertility through insurance or out-of-pocket affect patients. And studies should compare the difference in perceptions between patients who receive or do not receive psychosocial care and support. It will also be important to study patient-centered care for minority groups and low-income populations to see how race and socioeconomic statuses contributes to patients' experiences. So I would like to thank my mentor, Dr. Marissa Wise, Licia, Dr. BK James, and Dr. Sharice Hambling for the summer, and also the other doctors I had the pleasure of shadowing this summer. I didn't see any health disparities. I guess maybe the population at UPenn is mostly white patients, but we do see Black patients in the IVF, not a lot. I'm not sure if a lot of African American women know about IVF or even comfortable with discussing IVF with their doctors, but I did get a chance to see Dr. Wise talk to a couple African American patients, and I liked the way that she broke everything down and made everything easy to explain, so that was good too. All right.
So next we have Ariane Toy. She's been mentored by Drs. Lisa Levine and Dr. Eileen Wang. I think she's on the Zoom. Ariane is a class of 2021, and they're both in the Department of Maternal Fetal Medicine. So Ariane is a class of 2021 graduate from Hampton University, where she received her Bachelor of Science degree in biochemistry. Shortly after, she went back to her alma mater to further her education. She recently graduated in May 2023 with a Master's of Science in Medical Science, earning the top-ranking position in her master's program. As a young child, Ariane found labor and delivery fascinating, and this still holds true today. She's thankful for this opportunity to get a glimpse into her future. Ariane will be applying, or Ari as she goes, will be applying to medical school next year in hopes of pursuing her dream of becoming a board-certified ObGyn.
Good evening, everyone. My name is Ariane Toy. As Dr. James mentioned, I am a graduate from Hampton University, and this summer I did my research with maternal fetal medicine on the implementation and evaluation of a perinatal cardiovascular risk assessment algorithm to improve maternal and fetal health during pregnancy, peripartum, and postpartum, also known as Impact P3. So this summer I had the privilege of working under both Dr. Lisa Levine, who is the director of the Pregnancy and Heart Disease Program, as well as Dr. Elaine Wong, who is the director of Obstetrical Simulation. And so diving a little bit into my background information, the United States has the highest maternal mortality rate in the nation, being at 23.8 deaths per 100,000 live births. And when you break this down by race and ethnicity, non-Hispanic African Americans have the highest maternal mortality rate, being 3 to 4 times higher than any other racial and ethnic group. From the year 2018 to 2020, these rates were increasing, and unfortunately, they were still increasing after, as the rate from 2021 was 69.9 deaths per 100,000 live births. And so cardiovascular disease, as some of us may know, is the leading cause of death in the United States, and this still holds true today within pregnancy, as cardiovascular disease is the leading cause of pregnancy-related deaths in the United States. And some of these cardiovascular diseases include cardiomyopathy, arrhythmias, congenital heart disease, hypertensive heart disease, coronary artery disease, and some of these are indicated here in red. And so bringing it a little bit more local to the city of Philadelphia, from the year 2013 through 2018, there were 26 deaths per 100,000 live births, which is higher than the national rate, which I mentioned previously, being 23.8. And within the city of Philadelphia, cardiovascular disease is still the leading cause of pregnancy-related deaths, making up of roughly 50% of the pregnancy-related deaths in Philadelphia from the years 2013 to 2018. And so a little overview of the project. When individuals go in for their first OB visit, they'll be placed into one of these three categories based off of their vital signs and their history. And so individuals in the red flag category are going to have a resting heart rate of greater than 120 beats per minute, resting systolic blood pressure of greater than 160 millimeters mercury, resting respiratory rate greater than 30, or oxygen saturation less than 94%. And these individuals are going to be promptly evaluated or hospitalized, and then also have a consultation with the MFM or maternal fetal medicine specialist, as well as their primary care and their cardiologist. Individuals who do not have any of these vital signs in the red flag category, but do have a personal history of cardiovascular disease, are going to have a consultation with the maternal fetal medicine and their primary care and their cardiologist as well. Now, individuals who do not have any of the indications within the red flag category and also do not have a personal history of cardiovascular disease are going to move forward into the algorithm, which is the main focus of the overall project. And so the perinatal cardiovascular risk assessment algorithm uses the symptoms, the vital signs, the risk factors, as well as their physical exam to screen patients. And so if you have one symptom, if you have an addition of a vital sign as well and a risk factor, or if you have any combination of 4 or greater than 4, or if you have a physical exam that is abnormal, such as a loud murmur within your heart, or basilar cracks, which is going to be found at the base of the lungs, you're going to screen positive. Individuals that screen positive is not that they for sure have a cardiovascular disease, but they have an indication or possibility of a cardiovascular disease. And so individuals that screen positive are going to go through the first line testing, which results in the EKG, looking at the rhythm of the heart, as well as have blood work done, looking at their complete blood count, as well as their BNP, which is the type B natriuretic peptide, which seems to be elevated in individuals that present with heart failure. And so if any of these labs or findings come back abnormal, they will then go through the second line testing, which is going to result in the echocardiogram, also known as the echo, which is an ultrasound of the heart looking at the function. And so the purpose within this project was to incorporate a standardized perinatal cardiovascular risk assessment algorithm to facilitate earlier diagnosis and treatment of cardiovascular related diseases during and after pregnancy to decrease the maternal mortality rate. This was actually done in another study that was done in New York and California. However, the problem within this was that patients weren't going for their follow-up care. And so within this project, we're also trying to improve the follow-up of the recommended testing. And so the aims within the project, I'm only going to go through aim 1 for the sake of time and because that's the one that we're currently focused on. But aim 1 is to incorporate the cardiovascular risk assessment algorithm into the OB workflow, making it a routine basis within obstetrical care. Also to identify any of the barriers within or reasons why patients would not go through with their follow-up testing. Some of these include not knowing or having understanding of what they're supposed to do, so they don't do anything at all. Not understanding where they're supposed to go, so they don't go. A lack of understanding of the importance of the testing, as well as not having transportation, and then also dealing with echoes as it relates to their insurance. And so my role within this project was to establish a streamlined and easy to understand process for ordering and scheduling echoes. And I did this through understanding the process from a provider's perspective of ordering echoes as it relates to insurance, which insurances require prior authorizations, which ones don't, learning how peer-to-peers work as well. In doing so, I had to learn various terminologies such as the CPT code, which is the procedural code, and the ICD-10 code, which is the diagnosis code. I also had to understand the patient's difficulties and their frustrations, as well as understand the process of scheduling echoes from the patient's perspective. And so here's a list of insurances. These are not all the insurances that we partner with. However, this is a good start, showing the insurances that require prior authorizations for echoes and the ones that don't. Also giving a generalized schedule guideline, and one of the guidelines indicates that patients aren't able to schedule their appointments until they have this prior authorization. And some of you may be wondering what a prior authorization is. So a prior authorization is the approval that a provider must receive from their health insurance in order to do medical procedures or to prescribe medical or medications. And so I also created this navigation system, as I like to call the GPS, the generated pathway for scheduling. It shows the patient instructions for scheduling their own echoes, as well as giving them instruction on how to get their EKG from the time that the provider orders the echo or the EKG up until the time that they go to get it. I also created an information chart. Previously, we were only sending the patients to the Perelman Center to receive their echoes. However, recently we discovered that there are multiple locations in which they're able to receive this care. And so once I figured this out, I was able to create this chart listing all of the locations that they're able to receive their echoes, included the contact information down to the very small detail of what number it was that they're supposed to press when they got on this phone call, provided information on if there was an grace period, provided information on if there's an echo, not an echo, EKG, maybe they can get that done at the same time. And then also included if there was an EKG, is it walk-in or do they need an appointment? And then I also added if they need or where the echo is and the EKG is within the building. Now the problem with this, when I presented it to a community group, the community group was a group of physicians and lived experience experts who were patients within the Penn system or prior patients within the Penn system who now work along with the physicians in order to better the care for future patients. And so when I presented this and the information above to them, while they mentioned that this was a lot of good information, the problem was that it was overwhelming. And so after hearing all of their concerns and their suggestions, I then created another chart, has the same information, just looks a little bit more different. And so here is the other chart. What I did was I made it landscape, which was one of the suggestions, changed the color slightly. I also turned the rows into columns and the columns into rows. And then I broke down the information from the echo from the EKGs. And so here's the one for the EKG as well. And then I also provided a list of physical locations so that they don't have to look that up on their own. It's just easily provided to them so they can just put it in and go. So the next steps within this project, currently we're working on a website and an educational video, which is going to also eliminate that barrier or further eliminate the barrier of lack of understanding, providing them with information on cardiovascular disease as a whole, giving them information on who's at risk for these diseases, and then also providing them with information on how the algorithm works. And then we're also trying to make the information that I created, such as the GPS system and the chart, putting that into the electronic medical record system here at Penn, known as EPIC, and then also within my medicine. And then we're also going to progress forward with aims 2 and 3. And so the lessons that I learned within this research project, the very first lesson that I learned was that all clinical research is not the same. When I first got here, I was presented with multiple options that I could have chosen from One was where I was going to be recruiting patients. And then, of course, this one, which is the one that I chose, resonated a little bit more with me. And so the very first lesson I learned was that all clinical research is not the same. The next lesson I learned is that organization is key. In life, I tend to be a very organized person. However, with research, I had to be extremely organized. And so what I did was I bought a composition notebook and I jotted down each and every conversation I had from the time I got here up until the time that I finished my last conversation pertaining to research. And then I also learned that asking questions is necessary. While asking questions seems like common sense, everybody's like, okay, you should know to ask questions. I learned that asking questions was beneficial for me because in the beginning of my project, I knew what I was supposed to be doing, kind of, but it wasn't until I started asking more and more questions that I had a full understanding of what it was that I was actually supposed to be doing. And so these are the 3 lessons that I learned within my research. And then before I move on to questions, I just wanted to thank Dr. James and Dr. Hamblin for this amazing opportunity. To my amazing mentors, Dr. Wong and Dr. Levine, thank you guys so much for your support, for helping me along the way and making sure that I was going the right direction. And then to Miss Kathy and Miss Marlene, those are the individuals who I went to for all of my questions. So thank you guys for being available when I needed you and for being willing to answer my questions. And if you guys have any questions, you can do that now. Okay, so for the echoes, they'll have to schedule an appointment. So whatever appointment times they pick that's the time. Unfortunately. But for the EKG, if this walk-in basis for the Perelman Center is 8:30 to 4. For Penn Medicine at Radnor, it is 8 to 3. Few of the other ones require appointments, and then other than that, those are the only 2 that are walk-in basis. Per se hopeful. I don't know if it would be able or if the rates would go down. I believe education is one of the main factors in making this happen and making the rates go down. So yes, I do believe that it is something that can make it helpful, as such as the next steps within our project. So informing the patients, limiting the barriers, making sure that they're aware, because if they don't know that they're at risk, like some of us know, but everybody does not know that they're at risk. And so that was one of the main things that I actually brought up at the community meeting. They didn't specify who was at risk. They just said that it was people with medical conditions. Being Black is not a medical condition. And so I made sure that they put that as an emphasis that being Black is a risk factor. And so yes, education, I believe, is one of the main things that we can do now that is going to progress this forward. Thank you.
There's a chat from your other mentor.
Oh, how do I bring that up?
Last but not least, we're going to hear from Joanna Kyle, mentored by Dr. Rebecca Ham from the Division of Maternal Fetal Medicine. I don't know that Dr. Ham was able to join us. She may be on Zoom. Okay. So Joanna is a rising first-year medical student at Drexel University College of Medicine with interest in surgery, clinical research, workforce diversity, Latinx culture, women's health, and visual arts. She's undertaken administrative work at Patients Are Waiting this summer alongside her work in the program. She completed her Bachelor of Arts degree in both chemical biology and international studies at Case Western Reserve University in 2022, also minoring in Spanish and chemistry. She then received her Master's of Science degree from the Drexel Pathway to Medical School program in May this year. It is her ultimate goal to incorporate her diverse interests in medicine to better serve and connect with patients, and to continue health equity work and serve as a role model for Brazilian Americans. Joanna is incredibly grateful for this opportunity. Now, before she begins, I'll say that Joanna had unusual tech challenges, and her project involved EPIC, which her name got confused with a Wharton student, and she never really got her EPIC. So it's going to be a slightly different presentation from what we've seen so far, but nevertheless, in her true positive spirit, she made lemonade out of lemons, I think, and will present the rationale behind the study that she's doing with Dr. Ham. And she is going to be in medical school at Drexel, and they are planning to continue the work on the project. So Welcome, Joanna.
Hello, everyone. My name is Joanna Kyle. I am a little bit of an oddball out, being a rising medical student at Drexel, but being here in Philly has been incredible already. I just finished my master's at Drexel, so I've been here. It's been awesome, but I haven't had the pleasure or experience, spending time here in the Penn campus. So I just want to say thank you so much to Dr. James and Dr. Hamblin for making this summer possible for me, because it's truly been a balance of having this program and the incredible people here, but also my time at Patients Are Waiting, which is just eons ahead. So I'll start off with that. But yeah, the tech problems, that was something. I'll get into that later. But I guess I figured with this time I would definitely love to talk about the existing research that Dr. Rebecca Ham has done within the Department of Maternal Fetal Medicine. So the existing research and what I'm going to talk about revolves around this calculator, labor induction risk calculator, specifically for induced patients and their risk of having a C-section. So, alrighty, so here's the lovely Dr. Ham. This just happened to look like her a little bit, so I didn't make that. But yeah, so a lot of this was electronic based, so different than what everybody else had, which is interesting, but it's gonna be cool because I'll be here and I'll be able to continue along. So yeah, basically we're taking this risk calculator and we're implementing it into electronic medical records. So Epic, which is a very well-known, universally used health system, pretty universal, but it's primarily used by large US hospitals, health systems for storing, accessing, organizing, sharing records. And interestingly enough, I put here in my notes, Epic maintains 89% of the share for acute care US hospitals, so the largest share in the EHR market. So very important. But yeah, so she's been looking at investigating calculator use and birthing outcomes when integrated into Epic and nudged for use. So background. So zooming out here, labor induction itself is the process of stimulating uterine contractions. So natural birth isn't happening per se. But it's interesting, and just to throw out some statistics, I didn't know this, but for every 5 births, at least one of them is going to be an induced birth. So if you think numerically, that's about 1 million births per year here in the US. So that's a good amount. But interestingly further, within this 1 million group, about a third of them will end up being C-sections. So catching that and informing the patients of this risk through this calculator is kind of big picture what we're thinking. And it's a problem because maternal morbidity, I mean, Ari just did a great job talking about how horrible and alarming those statistics are, and that's the reality that we live in. And so anything that we can do technologically, face-to-face, interpersonally to alleviate these horrible statistics, let's do it. So here, this is a chart. I pulled that from Dr. Ham, one of her presentations she shared with me, because there's a lot of research and a lot of literature out there that I have been reading. And that was a large part of my summer too, is just reading a lot of the work that she's been doing. But here, let's see here. The figure just shows that once the calculator is implemented, a past study, they saw a 40% reduction in maternal morbidity. And you might be wondering, well, how? But I'll get into that. All right, so this calculator, who's eligible, why are we, so there are some criteria. 37 weeks gestation, you gotta be that or more. Singleton, so no twins, triplets, etc. No prior C-sections. Does not already have ruptured membranes, so everything's intact. And then induced, so labor induction, with an unfavorable cervix, so not dilated. Okay. So the calculator itself, it's in Epic, but it wasn't always in Epic, and that's a bit of the problem. So clinicians, if you're thinking stepwise, how is this being used? They're going to confirm eligibility in Epic, so that's step one. And then they're going to receive the risk percentage, and it's color coordinated, so this is pulled from Epic. You can see here, this column is what the calculator will spit out. And I love color-coded things, so this made me very happy. But yeah, so this is the labor board, the grease board. That's mainly what we're looking at visually. And it's the physician's job to counsel the patient given this number, make them educate the patient, have these conversations like, did you know, or you should know that given your parameters, which we discussed on the previous, right here, I'll read that out too in case you can't see. Height, BMI, cervical exam, history of pregnancies, and gestational age. Those are the types of things that you input. It's nice too because Epic has a lot of this information already, so it's a pretty seamless transaction. But having the conversations and educating the patient is really what this revolves around. All right. So the counseling part itself, once you get that number here, you'll fall in a certain category. So less than a 20% low risk. I won't go ahead with reading all this, but there were created scripts as to what you can say to a patient depending on how they fall on the scale. Now for me, I'm very much so, I hate robotically trying to report something. I'm very much so, you got to humanize it. So of course these are really helpful, but understanding who you're talking to, if they're stressed, if they're, you don't know anybody's situation to the T all the time. So knowing how to counsel somebody with empathy, but also genuinely trying to educate them as to their circumstance is a huge thing that I pulled from this. All right, so implementation, that was all background about what we're talking about, but now actually getting into logistics. And this is the part that I'm gonna continue to work on with Dr. Ham. All right, so previous challenge with this calculator, I just showed you guys how it was an Epic, but it wasn't always an Epic. Before, physicians, if they wanted to get this number, they had to navigate outside of the Epic website. It's not like it was a weird third-party website. It was like a NIH government official website, but it was an official calculator. It was just a problem of going out of their way and extracting this number. Who's going to do that? Who has the time for that? So convenience is a big thing. All right. So nudging this via that column, adding that right there, it's in their face, you should have this conversation. You should prepare the patient. You should educate them. So this has been used intermittently already at the hospital of the University of Pennsylvania, but it's been an inconvenience, so. All right, so with methods, it was implemented at a certain period of time, or at a certain point in time. So what I was gonna help Dr. Ham with, and what I'm gonna continue to do, is look at the charts and see when it was implemented, how did this affect the birthing, clinical outcomes, patient satisfaction, maternal morbidity. Those are all things that you can look at, you can record, you can analyze. So that's kind of the data we were looking at. So a lot of chart review, and that's where Epic, unfortunately, did me dirty. But looking at the pre-period on Epic, that's where I was gonna start. And you can see here the pre-period was October 2022 to April of this year, post-period being April to October. So the post-period is happening right now, and it will end in a couple of months. It's already August, which is insane. Let's see here. But yeah, data collected on all patients meeting the inclusion criteria. So that's very important. All right, so key ideas, takeaways from what I was able to gather. Medical records are very complex, and even during my shadowing experiences, I even had conversations with Dr. Sonalkar of do you like Epic? Is it, like the whole electronic medical record system really fascinated me because you have to be so meticulous. You have to be, it was very, very impressive to another degree that I had never really had experience with before. And I've worked with REDCap before in child psychiatry at UH back in undergrad, but I've never seen firsthand such meticulous chart work. So I was very impressed with that. But it's a very complex series of documentation. And Dr. Ham and I were able to go through a couple of patient cases together and kind of piece together this puzzle because it involved, like my role was going through the chart, gathering all of these different things. Like, did this patient qualify? What was the data? What happened? Was this calculator used? Did they have this discussion, this conversation where they counseled properly? And so sometimes we found that, the calculator wasn't used at all, or there was a huge chunk of the chart missing. And so there's this interplay between different care teams and all of their members that it's so important that everybody's on the same page and that everything's documented perfectly. So there's always room for improvement, of course, with anything, but that was just something that really, really stuck with me. So communication, complex notes, all that. But having the standardized use of a calculator, I think, it is the most important thing that I saw. And so nudging that, I think, having that streamlined process, using the calculator, at least incorporating it in a way that will definitely take time and patience and practice, and it's very heavily dependent on the individual. But I think it could tackle maternal morbidity rates continuously and to a larger scale. I mean, all of this has only been done within the University of Pennsylvania hospital system. So this has not been pushed nationally yet or anywhere beyond this health system. But I think a lot of the reading that I did this summer too involved a lot about racial disparities in obstetrics, which there's so much to read on that I didn't even know where to start with. I mean, I think the calculator facilitating some of these risks in the context of induced patients is a good start. There's a lot to be done, I think, still. All right, next up. Birthing satisfaction matters. So this quote really stuck with me. Here, patient satisfaction during labor is directly linked to mother-infant bonding, breastfeeding rates, and decreased risk for postpartum depression. Now, me with my background in child and adolescent psychiatry research, I worked on a couple different studies with childhood depression, and so that really stuck out to me. But the patient satisfaction is dependent on the patient. I mean, they're reporting how they're feeling, but it's what conversations did you have? How did you feel? Were you made aware of these certain risks? Did you feel confident in your care? Did you feel comfortable? Or did you feel more stressed out? Did you feel like it was robotic? So it matters, and we need to put their experiences and their health first. I think it's a complex relationship or dynamic between the two, but it can be done, I think. All right. So yeah, technology, timeline-wise, it was something else. At first, it was with my Penn key, I think, that then trickled down and affect everything else that happened. Because yeah, for a while I was in the system as Kyle Jordan instead of Joanna Kyle, and Kyle Jordan was somebody at Wharton School of Business. So I hope he didn't get any, or they didn't get any weird notifications. So But this has been incredibly, incredibly informative on electronic health records, to say the least. I knew a good chunk about REDCap beforehand with data collection and all that, because my role would essentially be, you pull up Epic and you pull up REDCap, and it's how, let's go through these charts, let's proofread stuff, let's piece things together and make sure we're pasting it in REDCap. Okay, so we have that data and everything's solid. So that was interesting to see, and that's what I'm going to be continuing. But the mentorship, the clinical and chatting experiences, it's been so cool. Even with IUD insertions, medical abortions, it's been an honor to see all that and to take part of that and witness such vulnerable, like we all have said, vulnerable situations, vulnerable interactions between people, and also to have patience that, you walk in a room and you're following the physician and the patient acknowledges you, the student, and they also talk to you and look at you and make you feel like you're a part of the conversation. It really sticks with you, and that's when I truly began to feel like, wow, like I'm being seen as a student, like I'm here. And it was really like a chilling moment where I was constantly reminded it's just such a privilege to serve for others and have them look at you and look to you for such personal things. And so I just wanted to say again, if I haven't said it enough, thank you so much to everybody here. You guys are incredible. Every single person in this room, I really appreciate you. Appreciate your time. It's been a pleasure being here, and the summer really did fly, but it's been awesome. So thank you so much. Thank you all.
Okay, guys, we are at the end. So before everyone goes, I just want to sort of say my thank yous for the program. You guys all did a wonderful job today, and really it wouldn't have been possible. It's all right. It wouldn't have been possible without support from so many. Dr. Howell is here, actually, our chair, who I mentioned. And then I'm going to let's do a clap. And I want to especially thank Licia, who's been running back and forth. She has been our coordinator for the program this year. She's a second year Perlman School of Medicine student. I think when we thought about this program, we were really intentional about making sure we had a coordinator that would be there for you guys. And she's done a wonderful job. Anything I've called her to do, she's done. We've got, I wanted a brochure this year, and she created that for us. Really, you've been just a joy to work with. I hope you continue to be interested in ObGyn. I know you're working with Dr. Sanalkar on some projects. We need you in the field. And then, of course, Dr. Hamlin, my right-hand person in this whole endeavor. You guys can see how invested she is in all of this. Her partnership means so much. And yes, again, to the faculty mentors, we couldn't do this without you guys. I know how much you pour into each and every one of these students, and they thanked you, but I thank you as well. And then POGA partners, I think, I'm not sure how many were able to join, but they have welcomed you guys and have been there and allowed you to shadow with them. We really do have a wonderful team here at Penn, and thank them as well. And then to all of our supporters, just in general, in any way. As I said in the opening, really with the Supreme Court decision to dismantle affirmative action, I think programs like this become so much more critical. All 5 individuals here want to be a doctor. I think this program has helped that possibility, has reinforced it for them, as each of them said. And I really think that it's just amazing that we've been able to do this. So with that, I will end. Thank you all so much for attending. Thanks to all the folks on Zoom. We've got some thank yous in there, things in the chat. And thanks to the friends and the supporters who've also joined. So that will end. Have a wonderful rest of the evening.